Morning, guys. Good morning. Good morning. Good morning. Happy Thursday. Hope you guys are doing well and studying hard. I know some people are on the West Coast and they wake up super early. So we thank you for that. At the same time, guys, you got to pass your test, right? So that's why we're here today focusing on NBMEs, right? To show you if you have to take an NBME, preferably if the school is expecting that of you, clearly you have to practice to do well. Yes, yes. So some of us here have to take an NBME. Some schools don't prefer it, or they prefer it, but it's not mandatory. Either way, we have to do very well on it, right? Between you and I, if you don't have to take an NBME, I personally would say this. I would say if you took 2-year-old self-assessments and you took the old free 120, the new free 120, and you did multiple blocks random timed in preferred Q bank, Amboss, Euro, you choose. If all the scores are above 65, 68%, literally above passing every single time, there is no indication that you won't do well on exam day. The only reason why we use NBMEs is because they are a good indication of your knowledge. There are 50 questions instead of 40. They're more challenging. They're short questions. So the reason why I'm doing them is A, if you have to take an NBME, you have to practice. So we'll do it twice a week, Tuesday, Thursdays. B, it's also going to show you what you know versus what you don't. And you have to pretty much think outside the box. They expect you to know all these pieces to get to the answer. So if you can physically do well on NBMEs, statistically, you can pass the step exam. Because if they spoon feed you everything in the Q bank, you do well. If they take everything away, but the bare minimum, and you still get the question right, there you go. All right. So I chose a few questions, pretty solid there, pretty good. Stuff that we've covered in class, stuff that we've seen before, and it pushes us to really think a little bit more and further from the actual question itself, right? It's the content. So raise your hands, let's get going. It's a Thursday morning. This afternoon, we're going to be doing hematology oncology because it's the 4th week of the month. Starting next week starts a new cycle, right? Brand new again, back to back. Every Monday, immuno, every Wednesday, micro, every Friday, biochem. So raise your hands up, guys. Let's do questions. I'm going to share my screen on this end, and we will do the first question. Dr. Patel, good morning.
Good morning.
Do you have to take an MBME, or is it preferred with your school?
It's right now it's more so preferred, because we've done some of them already.
I mean, if it's preferred, well, let me ask you, if you don't take it, will they still sponsor you for your exam?
Yeah, I already got my permit, so it's okay.
All right, cool. So this is just to practice then. And it really is, thing that I do here is stuff that we've seen before. Okay. So let's work a little step by step. Can you see the question okay?
Yes.
All right, let's do the question. Take your time with it and we'll dissect it. Go for it.
Okay. He is unconscious and his breath smells of acetone. He's only responsive to sharp pain. A rapid test shows a serum glucose concentration greater than 500. Which of the following best explains the patient's altered state of consciousness? And then I'm just going to go from the beginning. An 11-year-old boy is brought to the emergency department by the ambulance with his mother 30 minutes after she was unable to wake him from a nap. The mother states that he was recently diagnosed with type 1 diabetes and she has been having difficulty adjusting his insulin regimen. So it sounds like he's in diabetic ketoacidosis.
Good. This is what's happening. Yes. So now we know type 1 diabetes, high insulin. Now we have to figure out, why is this little boy having altered state of consciousness, right? Something simple that we know, but they can look at the answer choices. So power of elimination is big. Let's go one by one and see which one the answer is, Doc, which one we can eliminate.
Okay. I'm gonna keep A for now just because of the wording is kind of wonky for that.
Okay.
Uh,
So, okay.
and B, diminished transport of glucose across the blood-brain barrier. I would take that one off.
Okay.
Just because I don't think that has anything to do with the DKA at the moment. Um,
Okay.
C, excess free fatty acids in the CSF fluid. Again, I don't see that having to do with anything.
So B and C are out. Keep going.
Yeah. D, I would also take out inability of neurons to perform glycolysis.
Cool.
And then we're left with E and A. Intracellular.
So when there's extreme high glucose levels, well, what does that cause in the body?
So that's gonna cause like hyperglycemia.
Well,
So it could cause like seizures and stuff,
okay, and also severe dehydration,
tremors.
which then
Yes.
can cause delirium.
Mm-hmm.
And if you look at the other answers, altered affinity of oxygen from hemoglobin A1C
Mm-hmm.
versus intracellular and extracellular dehydration.
Yeah, I would probably go with E.
Yeah, exactly. E would be the answer because
Mm-hmm.
they take something so simple. They literally tell you type 1 diabetes. They say, hey, psst, type 1. And hey, psst, high glucose. So this is what NBMEs do. They spoon feed you, or you're lucky they give you this much. And then you
Mm-hmm.
have to think above it. You have to think above and beyond. You basically say, okay, well, there it is, right? Clearly, a person's diabetic ketoacidosis, they're unconscious, breath smells of acetone, response only to sharp pain. You should all have a clear indication and understanding why things happen. If you have high sugar, low sugar, what do we do with glycolysis, gluconeogenesis, right? Glycogen. If we are, let me ask you this, Dr. Patel. If you starve yourself for 32 hours, right? What is your primary source of glucose?
32 hours. So we're gonna be probably using for our 30, maybe probably our protein stores by then.
So the first, and guys, please chat away the answers as you go, or answer yourself, answer what I ask you. The first 24 hours, you have glycogen storage, right? So
Mm-hmm.
12 to 24 hours, your body is breaking down glycogen.
Mm-hmm.
Past 24 hours, you pretty much are tapped out. So if a person is starving, or trying to survive, or fasting, and they're not eating anything, just maybe a little water or coffee. Typically, you have gluconeogenesis is creating the glucose, or else you will perish, right? We need sugar,
Mm-hmm. Mm-hmm.
glycemic. So you said, how is it possible that people who are found in the mountains, or people who are starving themselves, still surviving past 24 hours? This is what they're going to ask you, right? Gluconeogenesis takes pyruvate and says, all right, I got to make glucose or else we're not going to make it. And then they're going to ask you about PP carboxykinase. They're going to ask you about step-by-step process sometimes, or at least the cofactors of the very important step, that instead of pyruvate shooting down to TCA cycle, we got to go back to gluconeogenesis. So, and this is cases that we've seen in the past, we keep seeing. So for me, to make my life easier, I remember cases we did together, aka questions, right? So I don't have to memorize. I just remember the case that we did, and then because that helps me. So this is by far very testable. This is diabetes type 1, ketoacidosis, and I can also promise you, we've done acid-base disturbances. We talked about metabolic acidosis, alkalosis, anion gap, high anion gap, normal anion gap. This is what you need to do. Terms are huge. That's why I select certain questions for us to do, because I need to see that you can see it. And I need those things to fire up, right? Because power elimination is big. So very good. Ideally, if you have any questions as we do these and say, oh, I got to go back, take notes, and then go back and reread a few things, because they will ask questions on glycolysis, genesis, and so on. So typically 12 to 24 hours is glycogen, typically, right? Everyone is different, but on the USMLE or exam, they won't say on the 25th hour. They'll say 32, 34, 36 hours. By then, your glycogen is all stored, all gone, and you're making glucose through gluconeogenesis. That's what happens. Ideally, that's standard. Okay, good, awesome. So I have more questions to show you guys. And again, this is NBME. So some of you have to take it, some of you not. So I'm here to help everyone because some people need to take it. All right. Now, read this question. This is a very, very, very good question that's going to push us to see what we know. I want diagnosis from you. And then we're going to start working about medication, treatment, and everything. So take your time with it. Let's attack.
Serum urine catecholamine concentrations are 4 times the upper limit of the reference ranges. A CT scan shows 2 centimeter nodule in the right adrenal gland. Which of the following is most likely responsible for the increased blood pressure in this patient after the propranolol therapy was started? Okay, so I'm going to go back to the top. A 43-year-old woman with a 2-year history of labile hypertension comes to the physician for a follow-up examination. Her blood pressure was ranged from 123/84 to 165/112 since being diagnosed. And one day after propranolol therapy started, she develops a severe headache and a blood pressure of 214/132. So I'm thinking this person has pheochromocytoma.
Okay, so the person has pheochromo, and I know we've done pheochromo many times. Okay, so she has pheochromo. Okay, continue.
And then okay, so then she's giving a beta blocker, but because with the beta blocker, it seems like it shoots up her blood pressure where it should be like doing the opposite of that effect because it's a
Okay.
non-selective beta blocker.
Yeah. So we give certain medications for pheochromo, correct? We give irreversible alpha blocker, and then we give a beta blocker. So we give 2 different.
Right.
So okay, keep going.
So it says what is most likely responsible for the increased blood pressure? Okay.
After we give beta blockers, why is this person having increased blood pressure? So, again, these questions are meant to see where you can connect. So go one by one and try to rule in and rule out, eliminate or keep in, see where we go from it.
So it wouldn't be A, it's not anxiety. Miclopano does treat anxiety, but that's not the reason here. Not the impaired degradation of catecholamines either.
Good.
Increased adrenocorticotropic hormone that has nothing to do with the blood pressure with the propranolol.
Good.
Infarction of adrenal tumor, nope. Nor would it be stimulation of aldosterone. Yes, aldosterone does increase blood pressure, but that's not the reason that propranolol is doing that. So I would do F because with propranolol, you're supposed to get like a week later, I believe. So they can because of the effects of like vasoconstriction.
So pheochromo, here it is. So pheochromo, learn everything about it because they will ask you, right? And then clearly we've done pheo many, many times. And if you look at both etiology, rules of 10, use it because they will ask you. Symptoms, well, we know how to pretty much pinpoint and pick pheochromo from crowded room, so to speak, right? Check this out. Treatment. Irreversible alpha antagonists, phenoxybenzamine, right? Followed by a beta blocker prior to tumorous resection. Alpha blockade must be achieved before giving beta blockers to avoid a hypertensive crisis. A before B. A before B. So if you get questions wrong, and I don't know what you guys know, do my best to help everyone, right? So if you realize, hey, my diagnosis is kind of poor, you have to fix it. Hey, I know my medication, but I don't know my adverse effects, fix it. Open up your first aid in front of you and or PDF. I like PDF because it's digital. You can type in one word and everything pops up with that word. Book, it's faster for me, more efficient especially. This is big, okay? So I'm happy you saw that. People can trip on it sometimes, but if you don't get tripped, and I'm happy you did well on this one, it also reinforces. And what I would suggest is